Great. Well, first of all, thank you for the invite to come and talk. So, 20 minutes on an update. Okay, this was quite tricky to sort of think about what things to pick out. So it's not all inclusive, but I thought I would pick out some things that were useful for clinical practice and also thought-provoking for you. Okay, so what am I drawing on for this talk? I'm looking at the literature body where it exists. And I'm saying that because there are still quite big holes in the literature that we need to see filled in, hopefully, in the years ahead. The Patello Femoral Research Retreat, this is something that's alternate years, and last year was in Manchester, and it's basically a sort of who's who of patellofemoral pain. It's all the big names in the field, in one room, presenting their research, and so, of course, it gives a very up-to-date flavour of the field, and I'll be talking a little bit about some of that work. And then my practice, which has now been exclusively patellofemoral pain for 10 years, so obviously there's a fair few patelli, quite a bit of pattern recognition, which I'm drawing on with as well, and then my own research as well. So just picking up a little bit from the talk we've just heard about terminology, I would really encourage you not to use the words anterior knee pain for patellofemoral pain. Not just because anterior knee pain is too vague in terms of the pathology, but also it drives you down the route of thinking about pain at the front of the knee. And patellofemoral pain can actually present medially, laterally, and also into the popliteal fossa. So it's actually quite misleading and inaccurate. I'd be even more careful about using the term chondromalacia patelli. So just to remind you, this is a descriptive term that describes the state of the retropatellar cartilage, and it can only therefore be given after arthroscopy or MRI. I would urge you to be really careful. There seems to be a lot of catastrophic beliefs around this that patients pick up on, and we do need to remember that cartilage is aneural, so it's not the source of the pain. It'll be the uneven joint loading, creating stress in the subchondral bone. It's not that retropatellar cartilage that's the source of the pain. So I would argue that that's one of the most unhelpful diagnostic terms out there. Okay, this model is not specific to patellofemoral pain, but I think that it really suits the field. So this model reminds us that there are three elements that we perhaps just always need to be mindful of. So on the bottom right, we've got things that would be local to the knee. So it might be fat pad edema, it might be, say, atrophy in the VMO, whatever it is, something local at the site of the knee. Then the bottom left, we've reminded that we need to think about the chain, we need to think about excessive pronation, femoral rotation, adduction, whatever it may be. So something in the region that may be influencing the knee. And then for me, an area that I feel is really underrepresented in the research body for patellofemoral pain is this top area here that we cannot leave out. And again, Mike mentioned nicely there that it's not just back pain. We need to remember a lot of these patients have had long duration symptoms, and so the likelihood is they will have an element of central change. They're often very anxious about what it means. And again, I would fully concur with what Mike was saying about take your time to educate your patient and explain that just because they have knee pain doesn't mean they have structural damage. So in keeping with this top area of this triangle, is an area of my research. This first paper of mine was an editorial I wrote in 2010, just putting it out there as a suggestion that patients get very stressed and anxious about their crepitus. And I was very fortunate to be awarded a research grant to research this, which I've been doing in the last couple of years. So I've been doing semi-structured interviews with patients with patellofemoral pain with a normal MRI, and that's a really important point in this research. I've been asking them about their crepitus, been asking them about what they feel it means to them, and here are just some quotes that I've got so far. It means my knee is wearing away. It means I have arthritis. It's my body's way of telling me to slow down. I even had a 26-year-old male who was house hunting, and he said, I'm so perturbed about the noise in my knee, I've decided to only look at ground floor properties. He's got a normal MRI. So, and I also asked these participants, if you had an exercise given to you by a physio, and when you were doing it, your knee made its noise, what would you do? Every single person said, I wouldn't do it. So I think, as quirky a topic as this is, I think it's something that we need to be aware about. And I think we need to educate the patients that really it's a normal phenomenon across the population. It does not necessarily correlate with severity of pathology, and it's the pain is the abnormality. And I would urge you to manage the expectation along the lines of, we're aiming to change your pain. Your noise may remain. Because if they're still avoiding the stairs because they hear the noise and the noise for them means damage, then we have a problem if we haven't addressed that. So one really quick and easy question that I ask in my clinical practice, if they mention crepitus, I just say, what do you think it means? And if they say, oh, I don't know, worry about it, don't think about it, fine, move on. But if they say, well, it means my knee's very arthritic, then I need to stop and address that belief system. Okay, moving on to another area of my research, VMO, very controversial. Is it an area we should be completely putting to bed and forgetting about? Okay, what do we know definitively? We know definitively we cannot recruit the VMO in isolation. And we know that for many patello femoral pain patients, it's not a causative factor. They might have a little bit of loss from disuse or altered use, but it's not a causative factor. Personally, the ones that I think it becomes relevant are from the ones that have a history of a lot of pain or swelling early on in their history. So, for example, a fall onto the knee, a heavy fall, a very painful, maybe they have an effusion, or the patients that are post-surgery. They've had a straightforward meniscectomy, they then get a bit of an effusion from the meniscectomy, the meniscal side of things is fine, and now they've got raging patello femoral pain. So look for those clues in the history around pain and swelling. So the work that I've been looking at with an anatomist for the last 8 years now is looking at muscle architecture. So this isn't anything to do with EMG or firing. We are taking the fibre angle relative to the femoral axis and the amount of muscle inserting onto the medial border of the patella. And we've been looking at this. So what we found, and this was the first paper in 2014, Angelina, the paper showed that in 80 knees that we ultrasounded, 80 normal knees, the muscle architecture varied hugely. So some people had a very vertical VMO that was at 40 degrees, and other people were around nearly 70 degrees. We also found that the amount of muscle inserting onto the medial border of the patella was even more varying across the population. So some had a third of their patella really with a VMO attachment, and other people it was right down that medial border. So then we looked at, well, does this depend on how active you are? So we did another study where we correlated it with TEGNA scoring, so basic score of activity. And sure enough, we found if you are sedentary, you're more likely to have a vertical, small fibre angle and small insertion. And if you're very active, you're more likely to have muscle architecture where the VMO is round, more near 70 degrees. So then the burning question is, can we manipulate this? So this was the next paper we looked at. So we took sedentary people. So this is important to remember, it's sedentary normals. And we measured their fibre angle. We put them on a very basic quads program for 6 weeks. And then we measured again. And we found that the VMO fibre angle changed significantly. And the smaller the angle to start with, the bigger the change. We've also subsequently gone on, but it hasn't been published yet, to look at closed chain versus open chain, and they had the same effect. And then we've also looked at closed chain versus closed chain with muscle stim, and the muscle stim group had a bigger effect. We've also looked at what happens when you stop. So we had a 3-arm trial. First group carried on until 12 weeks. Second group stopped dead at 6 weeks. Third group just did a minimum twice-a-week program. The group that stopped started to regress a little bit. The group that went on to 12 weeks carried on having further change, and the group that did 2 exercises twice a week managed to hold the architecture change. So we're now going on to looking at muscle architecture with stretching, and we're also going to start looking at the effects on the vastus lateralis. So this is really quite a different paradigm, a different approach to looking at the VMO moving away from EMG. Okay, now we often think about the VMO with respect to dynamic stability. So I want to talk to you now a little bit about patellofemoral stability. So I often think about it and say this to the patients. It's a bit like a tobogganist entering the ice luge. You want it good central position to start with at the beginning and all the way through range then, so that the load is spread evenly on the retropatellar surface. So dysplasia, this is a really emerging area now in the field, and some of that's due to the improvement in imaging. And looking at dysplasia very much on a spectrum. So on the one hand, we might have here a totally normal knee, and then on the other end of the spectrum, a grossly abnormal knee, maybe a dome trochlea, hugely lateralized tuberosity. But the reality is there's a lot of patients that sit in the middle who are subtly dysplastic. And the trochlea shape, patellar tendon length, and tibial tuberosity position are all things that we should be considering on this spectrum. So obviously I'm interested in non-operative care. So if somebody has a large TTTG, and just to remind ourselves, it's a bit of a mouthful, isn't it? TT, tibial tuberosity, one line through that. TG, trochlear groove, another line through that. So we want those 2 lines essentially to be on top of each other. We don't want a big distance. And the TTTG is the distance between these 2 lines. Roughly up to 15 millimeters would be classed as normal. 15 to 20 millimeters, that's starting to get quite lateralized, but they should hopefully still be able to be stable. Beyond 20 millimeters, you're into the realms of high risk for dislocation. So if someone, in essence, has a large TTTG, it means their tuberosity is lateralized. So it means, in essence, think of it as a large Q angle. So it's going to overload the lateral facet and overload that lateral element of the patellofemoral joint. So what I'm immediately thinking in my mind is, if they've got that lateralizing force on their tibia, the last thing this patient can cope with is a medializing force at the femur. So I'm really interested in their adduction, internal rotation, or combination of, because think of it like a shopping bag of risk factors. If the tuberosity is in there as a risk factor, we can't change that without surgery. So we can change the medializing effect above it to try and minimize that sort of pure, that Q angle that already is compromised. Patella ulcer. So true patella ulcer, just to remind ourselves, is a long patella tendon. And quite simply, the length of the tendon and the length of the patella, as a rough guide, should be a ratio of 1 to 1. If you're in clinic with a patient, you don't have imaging, I put my hands on the patella like that, I put another finger on the tuberosity, I want to see roughly that my hand's looking like that, not like this. So again, non-operative management here. So let's think about the implication of a long tendon. It means the patella starts high. So when they flex the knee, it's going to take longer for that patella to descend and reach the stability of the trochlea. So even if they've got a good trochlea shape, they don't have the benefits of it for further interflexion. So they're therefore more unstable in that very first bit of knee flexion. So where do we need to target our rehabilitation? In that range. Give them the stability where they need it. And because of the nature of the patella being positioned high, they're essentially multi-directionally unstable. And again, thinking about the VMO work that I've been talking about, if someone's got a high riding patella, they're going to need as much dynamic stability as you can offer them. And I would suggest, although all our work's been done on normals so far, that a VMO that is good fibre angle, good insertion is going to help with that. So then we come on to trochlea shape. So again, thinking non-operatively here, they can have multi-directional instability. They're not necessarily going to even mention stability. They might mention something like, I feel like my patella is slipping. They often use a word like that. But they might actually just report pain. So do remember that pain can be, in essence, a stability problem. I personally, this is anecdotal, but think that they often have small patellae. I think it's often part of a global picture of hypermobility, hypermobile, and a poor trochlea shape. You need to try and establish, if you can, are they subluxing, are they dislocating, or is it just general excess mobility? And often I think they come in and they're quite puffy in their parapatellar soft tissues. You might think, oh, have they got an effusion? Actually, they don't have an effusion. They're just puffy, it's slightly edematous because the patella's crashing around into everything around and about the patella. If the problem is with engagement, then thinking about, again, that early range of movement to help with engagement. Think about that luge analogy, getting the tobogganist into the right position. Avoiding pain is so important in rehabilitating using quadriceps strength work. If there's one message I would say actually from this talk, it's don't give out painful quadriceps exercises. It not only often creates further inhibition, it actually also loses the confidence of the patient in rehab as a whole. So don't give out painful quadriceps exercises. Isometrics are very useful if they're subluxing, so that they're not moving a lot and subluxing, which can hurt. And often they'll have Hoffer's fat pad edema associated with this, and we talked about the fat pad problems before. Often the patella femoral and the fat pad go very much hand in hand. To give you an example, if I saw someone with a lateralized tuberosity, I'd expect they would probably have more of an issue in their lateral fat pad because of all that compressive force on the lateral aspect. If they've got a shallow trochlea or a patella ulcer, because it's more multi-directional instability, you might see fat pad edema medially and laterally. So that's a clue again. And on MRI, if they've got bone edema, do consider bracing. I know Michael's here. I saw him in the audience just before. This is a great paper, and I'm not just saying that because Michael's here. This paper really elegantly showed this in people with lateral patellofemoral bone edema who were put into this Q brace that for a mean of 7.4 hours a day for 6 weeks, they had a significant reduction in bone edema and correlating reduction in pain. And it was really interesting for me, this paper, because I already used this brace, but I used it differently. I used it more with patients when they were doing a sort of higher stress scenario, like trying to go to the gym or going for a long walk. So actually, this has changed my practice to viewing this as a treatment for people with that laterally positioned bone edema. Not all patients have the best shaped legs for braces, so if you have a wider thigh, shall we say, you might find that you can't get them adequately into a brace like this, and then I would consider taping to replicate the same effect. So just coming into the last area I wanted to pick up on as sort of emerging, and the area where there'll be a lot more literature, I'm sure, coming through, is running. There's lots of inconclusive literature. There's lots of work on change in stride length, etc., which I'll talk about in a minute. Not that much, actually, on painful subjects, but work to look out for a gentleman in Canada, Sculia, who's doing some really interesting work around education. He's doing his PhD on education of runners with patellofemoral pain and looking at that versus strength work. And his preliminary findings are showing that actually the role of education in terms of not running technique, but running frequency, having rests, warm up, cool down, all of the very generic advice is actually very helpful. Some really interesting work coming through on footwear at the moment. Interestingly, actually, this paper published this year has demonstrated higher patellofemoral joint force with maximalist shoes. So you might think, well, why is that? And conversely, we know that with minimalist footwear, when people are running light on their feet, you can really reduce the patellofemoral joint force. So actually, it's probably around what happens running technique-wise when someone's in a shoe. So if they're in a really cushioned shoe, maybe they're crashing around because they feel the shoe is offering up the protection that they need. And actually, really useful tip, just getting patients to really think about running light on your feet. So not necessarily changing them into a forefoot runner, but making sure, particularly if they train on a treadmill, they're not really crashing around on that treadmill. A few other bits about running. There was a sort of plethora of literature that came out a few years ago around step rate. So obviously if you up your step rate, you reduce your stride length. And this seems to reduce patellofemoral load. It reduces peak hip adduction angle, which is very often a useful thing in these patients. Reduces work on the hip abductors, so hopefully they don't fatigue so rapidly, and the external rotators. And we get better firing of gluteus medius prior to heel strike, which is going to facilitate a stable pelvis. Now, barefoot running also reduces patellofemoral joint load, but it decreases stride length, so perhaps it's just doing it through reducing stride length. Tang's paper showed that increasing trunk forwards lean will decrease patellofemoral joint contact pressure. I'm not so keen on that myself. I think you potentially just move the stress to the hip or the low back, but it is a strategy that I know some people have brought about successfully. So that's a sort of whistle-stop tour of a few bits and bobs that are coming out at the moment, things to hopefully highlight for you to be aware of. I've got a website that's full of information and CPD for yourselves or patients, so do feel free to have a look. Thank you.